Basically, you and your partner get dispatched to an apartment building for an 18-year-old female with shortness of breath. Now, the differential for shortness of breath is pretty broad, right? There's some big ones that I always keep in mind every time, but like, kind of at least for me, these are the big ones I always try to think about. These are the ones I always want to rule out every time, right? Of this list, it's important to always keep in mind that metabolic issues and like cardiac issues and, not just lung ones, right? For instance, DKA presents with shortness of breath all the time, especially in like underserviced areas where patients may or may not have access to diabetic care and close follow up. Just because you're going for shortness of breath doesn't mean you're going for a lung problem. So it's always good to keep your differential wide. So you pull up to the apartment and you head upstairs to apartment two. And you find Rose laying in bed. Rose is an 18-year-old female. Her boyfriend called 911 because she has been acting funny for the last few hours and kind of seems to be breathing really hard. And she's been sick for a few days with like a flu-like illness. He's kind of concerned, right? So basically, she's been short of breath for 4 to 5 hours, and she's been altered for about an hour, hour and a half, somewhere in there. So Rose is an insulin-dependent diabetic. She's supposed to take insulin twice a day, but she doesn't. The boyfriend doesn't know like what. Um, Basically, he states that she didn't take it yesterday or today because she wasn't really eating due to feeling sick, and it sounds like she hasn't been taking her insulin. From a physical exam perspective, she's alert. She's alert times oriented times two. She's definitely altered. She's breathing pretty fast at 40. She's taking these big big deep breaths, right? She's got clear lungs. She's got a non-productive cough. She has dry skin, good perfusion, normal pulses. Her abdomen is soft, non-tender. She does have some abdominal pain. And your partner obtains these vital signs. So she's tachycardic, she's hypotensive, just borderline. Respiratory rate's still 40, SpO2 is fine on room air, and she has very, very minor temp. So, with that, what have you narrowed your differential down to? For me, I'm like 99% sure it's DKA at this point, but I really want one more vital sign to prove it to me. So, what vital sign am I looking for here? I want a glucose, right? Technically, there's something called euglycemic DKA where patients have a normal glucose, but those are like specific patients with like specific meds that cause that. And she isn't on any of those. She just takes regular insulin. So, for her, we'd expect her sugar to be high. And it is. It's 154 milligrams per deciliter, which is the equivalent of 30 millimoles per liter. So she has an obviously high blood sugar. To me, this is a slam dunk answer, right? She's in DKA. So today, let's kind of talk about DKA, diabetic ketoacidosis. So, what is the main source of energy for our cells? Food, right? Carbs, glucose, sugar, right? The body basically breaks these things down into glucose, simple glucose, and glucose is the main source of energy. Basically, you get ATP production is achieved through oxidation of glucose molecules, right? It's the whole cellular respiration thing that you learn about in high school bio. Basically, you get glycolysis, the Krebs cycle, and the electron transport chain. And this is just a picture of the electron transport chain. Basically, you get sugar and oxygen, and you turn it into CO2, water, and energy, right? Hopefully, that all kind of rings a bell. It turns out glucose can't actually get into the cells on its own, even though every one of your cells needs it. It needs to be let in through glucose transporters. So it needs a key, basically. And basically comes over, binds to a receptor, and then it will trigger those transporters to come to the surface. And they do, right? They come to the surface, and then all of a sudden your glucose can enter. Where then it will travel to the mitochondria, and it'll go into the whole energy production thing that we just talked about. So, what is diabetes? Diabetes describes a group of metabolic diseases characterized by chronic hyperglycemia and insulin resistance. It's associated with a relative or an absolute impairment of insulin secretion, along with kind of varying degrees of peripheral resistance to the action of insulin itself. So basically, no insulin, no glucose, no energy. So we hear about these distinctions. What's type 2 versus type 1 or whatever? What type diabetes and what's the difference between the two? So in type 1 diabetes, the body doesn't make any insulin. There's no insulin. You're in an absolute deficit of insulin. In type 2 diabetes, the body makes some insulin, just not enough, right? And this could be like you have a pancreatic problem where your body isn't producing enough insulin, or it could be like, you've gained a whole bunch of weight recently and now you have more cells to feed. You don't have enough insulin, right? Um, you know, it could be from a variety of reasons, right? But this isn't a talk on DKA, or this isn't a talk on diabetes, though, right? We have full lectures on that stuff on the website. I want to focus on the insulin and DKA. However, I will say that I don't like the whole type 1, type 2 split. It's just the most common way it's split up. I like insulin dependent diabetic and non-insulin dependent diabetic, because your type 1 diabetics will always be on insulin. Your type 2 diabetics can be on insulin, and then they're going to present similar to a type 1 diabetic anyway, right? So even though they're not, so I like insulin dependent, not insulin dependent, but that's just me. So as it turns out, insulin does a lot. One, it lets glucose into cells, right? We just went over that. And that's the big function that we learn about in paramedic school, right? But it also stops something called lipolysis. And this part is actually really important in DKA. Lipolysis is our kind of starvation backup system. So normally, right, we eat a meal, we break it down, the insulin lets the glucose in, the ATP production happens, and the energy, right? Well, in starvation, there's no meal, right? So there's no glucose. So we have to use a backup plan. And that backup plan, part of that backup plan is lipolysis, right? So we basically take free fatty acid production and then use that as an alternative fuel for energy. It's not nearly as efficient. And then the other jam is that it has a whole bunch of byproducts. One of the big byproducts is ketone production. Basically, insulin stops this process and prevents excessive lipolysis and ketogenesis. You actually only need a very little bit of insulin to stop lipolysis. Um, you you don't need a full insulin. So like your type 1 diabetics, for example, are at greater risk of this than like your type 2s because they still have some insulin. It's kind of interesting. Anyway, we'll go over it later. Insulin also promotes glucogen synthesis. Sorry, basically it's just the stored form of glucose, so it'll store it in the liver, and then it suppresses gluconeogenesis and glycogenolysis, which basically allows us to make glucose from non-carb things, and then allows for the breakdown of glycogen back into glucose, respectively. So, what happens when the body doesn't have enough insulin? The cells starve, right? They can't use glucose. It tricks the body into thinking it doesn't have any glucose. And this is actually the key to DKA and HHS. The body has glucose, it just doesn't think it does because its cells can't use it. Basically, the traditional thinking, right? The body can't use glucose, so glucose builds up. And after this doesn't make a lot of sense, right? Basically, the traditional thought and how people often describe this is that you have all of this glucose floating around, and like because you can't use it, your glucose goes to 800. And no, that's not how this works, right? Think about the biggest meal you can think of. If I ate a giant turkey dinner with Thanksgiving, right? What's the highest my glucose is going to get? 250, right? Not 600. So true, right? Glucose isn't getting into cells, it's building up, but you're also peeing most of that out, right? Hence the name diabetes mellitus, right? It's sweet urine. You're peeing a lot of that glucose out. So something else has to be happening. There's a reason the blood sugar gets to 6, 7, 800, and it's not because your body isn't using it in the cells. The myth is that the reason the glucose is high in DKA is because the cells can't use it and it builds up in the blood. And this isn't true. It's from glucose production, right? The body thinks it's starving because it's not getting glucose into cells. This releases stores of glucose, right? Your body goes into panic mode and releases a whole bunch of glucose, which actively adds glucose into the circulation. Your body's pumping glucose into your vessels. And this is what causes the massive hyperglycemia, which ultimately results in something called an osmotic diuresis. Basically, sugar is a really big molecule and it pulls water into the circulation with it. And the body then thinks it has way too much water because it just pulled a bunch of water. So what does your body do? It pees out all the water. So that's where you get this like really bad hypovolemia from. In your average DKA patient's 5 to 8 liters down. And this is why. because there's glucose just kind of sitting around in the blood vessels. You pull a bunch of water, and your body's like, "Oh, way too much water," and pees it out, even though you actually needed that water. The other jam with that is that electrolytes follow water. So you get electrolyte depletion as well. Specifically, you get potassium, sodium chloride, magnesium, and phosphorus can all be kind of put out of whack due to this osmotic diuresis. And this happens in both HHS and DKA. Speaking of that, what is the difference between DKA and HHS, and what is HHS? So HHS is hyperesmolar hyperglycemic syndrome, and DKA is obviously diabetic ketoacidosis. HHS is more of a longer term thing, and it has a far more profound dehydration associated with it. Basically, it's a hypovolemia and electrolyte problem. And this is why the sugar is traditionally higher in HHS, right? Your DKA patients will have like a blood sugar of 500. Your HHS patients will have a blood sugar of like 1200, right? And it's because it happened over like the course of 3 weeks where there's just been this constant dehydration electrolyte shifting. DKA is an acidosis, right? It's ketoacidosis, right? The acid is the limiting factor in DKA. This is why DKA patients present in 2 days, not a week. Why their blood sugar is 600, not 15 billion, right? Because it's caught quicker. Because it's not a fluid loss problem; it's an acidosis problem. The acidosis happens pretty quickly. So these patients call for their shortness of breath, or because they feel really terrible, not because they're peeing a lot and because their blood sugar's high. The DKA is an acidosis issue, and it's the limiting factor in DKA, and that's why the blood sugars aren't as high. That's why it's a big difference between the two, right? In HHS, you're traditionally talking type 2 diabetics, right? These people still make insulin, just not enough insulin. So it's, they don't make enough insulin to have energy, but they still make enough insulin to suppress starvation and lipolysis. So they don't get free fatty acid production, which means they don't produce ketones. They still have a little bit of insulin floating around. They're not in a full starvation. They don't have enough, and their body wants more, and it thinks it's starving still, and you have all of those other issues, but you don't get the really bad lipolysis, ketonemia, acidosis aspect. In DKA, which is traditionally your type 1 diabetics or your insulin dependent diabetics, sometimes they're type 2, you have a complete insulin deficiency, right? There's no insulin. So there's no suppression of lipolysis. So then we get the free fatty acid production, ketones, and the severe acidosis. So this whole process stresses the body out. What does that cause? A big catecholamine dump. So what does this do? What does the catecholamine dump do? Ultimately, it releases more glucose, right? It worsens the cycle. Then depletes your reserves, which just causes more stress, right? It's this like spiral. Basically, it's counter-regulatory hormones worsening DKA. So basically, your body's all stressed out because of the DKA, so it releases a whole bunch of catecholamines, which then make the whole thing worse because that releases more glucose, and that glucose releases more get more diuresis. Your body thinks it's starving more. You get more lipolysis. It's this big kind of spiral, right? DKA isn't a sugar problem. It's a counter-regulatory hormone problem. It's an epi problem. It's also an insulin problem, right? Still not a sugar problem. And it's an acidosis problem, right? The big DKA issues that we talk about. One, the ABCs, just like anyone, right? But then hypovolemia, right? And that's because of that osmotic diuresis. Then you can have your electrolyte abnormalities, which is also because of that osmotic diuresis, also somewhat of the acidosis. Then you get your ketoacidosis, right? And that's from that free fatty acid breakdown. Then you get your altered mental status, and that's actually just from the brain not getting glucose, right? Your brain needs glucose too. It's not getting into those cells either. Then you have your underlying problem, and we can't forget this one, right? DKA oftentimes doesn't happen on its own, and it certainly can, right? It's usually due to med issues. So 60% of 41 to 60% of DKA is a med adherence problem. They forgot their insulin. They didn't take the right amount of insulin. They ate too much and then didn't take insulin. It makes up a part of it. Um, but you also have to remember that there's a reason they went to DKA, even if it's not we didn't take our meds. It's you know do they have infection? Do they have a trauma? There's some precipitating cause. There's something called the 6 I's. So there's Insulinopenia or insulin deficiency, infection, ischemia, inflammation, intoxication, and impregnation are six of the big causes of DKA. Then obviously your trauma. The big one's med adherence. The next biggest one's probably new onset diabetes, and then infection after that. The new onset diabetes is interesting. So this is especially prevalent in kids. So you'll have like the 3-year-old or the 5-year-old who is in like horrific DKA with a really low pH and they look super sick with no medical history at all. It's just because they just weren't diagnosed with their type 1 diabetes yet. This is the presentation of their diabetes. Like this is congratulations, you're now a diabetic. So that can happen too. They just have new onset diabetes. All right, so we know it's diabetic ketoacidosis, right? We can't forget the acid part. This is why they present in the first place, and it's why they breathe so funky. So it's a big part of what we see. Hopefully, you recognize this kind of formula here. It's the bicarbonate buffer system formula. And basically, in DKA, you have this acidosis, which adds a whole bunch of hydrogen ions, right? And then you throw bicarbonate, turn it into carbonic acid, and eventually you turn it into CO2 and water. And then you try to breathe out that CO2. Think of CO2 as liquid acid, right? Because of how your body uses this equation, when you retain a bunch of acid, your body's going to throw a bunch of stuff at it and turn it into CO2. And you need to then blow out that CO2. And this is why they have Kussmaul breathing, right? That's that deep, rapid breathing. They're increasing their tidal volume and they're increasing their respiratory rate to increase their minute ventilation to blow off all of the CO2 and to blow off the acid. And that's kind of the mechanism there. So, um, common physical findings, right? Um, CNS perspective, we get polydipsia, polyphagia, so wanting to eat and wanting to drink, lethargy, stupor, Kussmaul breathing, polyuria, ketonuria, glucoseuria. So basically, they pee a lot, they have ketones in it, and they have glucose in it. HEENT perspective, the blurred vision, smell of acetone on the breath, which I have never smelt in my entire life. I do lots of DKA patients, right? Like in critical care and flight, we do these all the time. They're like a bread and butter call for us. And I have never smelled the fruity odor, acetone breath. I've had partners who have, and patients that I've been standing next to, and I just can't. I'm apparently one of the people who can't smell it. So I think it doesn't exist, but apparently it does. And then GI, you can have nausea, vomiting, abdominal pain, those types of things. So we know our patient has at least some of these, right? She's lethargic, she's stuporous, she has Kussmaul breathing and abdominal pain. She could have more, right? This is just a quick case and isn't a full assessment because I got lazy, but she could have more of these things. From a diagnostics perspective, to diagnose it in the hospital, you need a blood sugar greater than 250. That's actually important, that 250, lower than you think it is, right? So someone can be in forward decay with a blood sugar of like 255. It doesn't have to be 9 billion. It doesn't have to be 800. It doesn't have to be high. 250 is the cutoff. It's lower than you think. Then you have your pH less than 7.3, your bicarb less than 18, and then positive urine ketones. They can also do something called a beta hydroxybutyrate level. Not so important for us. So for us in EMS, we can check her glucose, right? And we know her glucose was 540, so she's obviously hyperglycemic. So how do we treat DKA? Don't worry, we'll kind of go over these one by one, but we basically have A and B support, fluid resus, electrolyte repletion, insulin, and then underlying issues. The big A and B support thing, airway and breathing, is to not intubate these patients, right? They are attempting to compensate. Help them compensate, right? Put them on BiPAP, put them on oxygen, whatever. Intubating them should be an absolute last ditch effort. Like these folks do not do well intubated and they do not do well on vents, and you can murder them incredibly quickly by pushing your drugs. This isn't an acidosis and intubation talk, so we'll kind of move on from here. But just know you absolutely try everything in your power to not intubate these patients. Don't intubate the DKA patient. It's not going to be a good time. From an O2 perspective, these patients usually don't have an O2 perspective. They don't have a problem. Usually they're breathing more so than usual. So I've always had them have normal sats, but technically they can be low. So O2 should always be considered if, sats would dip below 93. All right, so volume resuscitation. So Volume resuscitation is actually really important in these patients. We do this first, right? And the reason we're doing this isn't because they're super dehydrated and hypovolemic, which they are, right? They're 5 to 8 to 10, liters down. The reason we do this is it decreases the circulatory stress. You're not diluting the glucose. Fluid resuscitation has absolutely nothing to do with deleting or diluting the glucose. You are giving your initial volume resuscitation to decrease the circulatory stress. These are hypovolemic patients. By decreasing that circulatory stress, you can actually decrease their glucose because you're decrease their counter-regulatory hormone levels. They don't have to dump epi all the time. You're fixing their shocky state, so it gets better. And they don't have to produce a bunch of glucose, so that gets better. It's not going to fix it by any means, but you can actually dip your glucose by giving a decent fluid resuscitation. It should be one of the first things we do, and it's usually done before you give insulin. It's usually done oftentimes by EMS. They usually get a liter, and then you'll start your insulin. So it's actually important in these patients, right? Basically, you want to assume there's a 10% dehydration in DKA patients, so 100 mLs per kilo roughly deficit. And that deficit needs to be corrected over 36 to 48 hours, not 20 minutes in your ambulance. Now, how I do it is if the patient's hypotensive, I give a liter, right, of either LR or normal saline. And I usually give that over like 10 to 15 minutes. So a bolus, right? And then I'll give 500 mLs an hour for the next like 2 to 4 hours, depending on, how far your transport time is. You're probably not going to get that much in. But I at least want a liter, and then I'm going to give a decent amount after that. If they're normotensive, what I'll do is I'll give the first liter over 60 minutes. So however math that works during your transport time is how it works, right? And then again, it's 500 mLs an hour for the next couple hours. Now, eventually these will be changed to like D5 NS, D5, D5 half, D5 normal, and that'll depend on like the DK later on and like when their blood sugars start to come down. You'll add sugar so you can keep closing the gap but still have sugar and not close that too quickly, and it gets complicated. The big debate for us is saline versus LR. Ideally LR, maybe. The basics kind of trying to put a damper on that, right? So in 2021, the basics trial came out, and it used to be like, we should prefer LR to all of our, massive resus patients because saline has like a hyperkalemic metabolic acidosis associated with it and all these other problems. And turns out basics was like, probably doesn't matter. Some more research needs to be done. Basically, do whatever one you have, and it's probably fine. All right, so electrolyte repletion. The big ones here are potassium, mag, phosphate, and bicarb. Not so much the bicarb, but like it's one that we talk about. Potassium's the biggest one, right? Potassium will be falsely elevated due to the acidosis and hypovolemia. You usually have a potassium deficit of like 200 to 1,000 milliequivalents, like a pretty good potassium deficit. If the K is less than 3.3, you can't even start insulin yet because insulin's also going to switch that potassium around. So potassium is really important in DKA, and it's something that these patients will be on continuous potassium replenishment throughout. So even if someone like presents almost like hyperkalemia, it's a false hyperkalemia. Their whole body potassium low. They've just shifted it. Insulin could be held for this kind of a thing, right? So not really an EMS thing, but something to be aware of. When it comes to bicarb, it can be considered. I'm not a big bicarb fan. Bicarb just turns into liquid CO2, and if you're not breathing for them already, or if they're already maximally compensated, you're going to mess them up. We do not give prophylactic bicarb. Basically, bicarb is reserved for patients who have a pH of less than 6.9 or in cardiac arrest. Next is insulin. This is actually the treatment for DKA, right? This is what the patient actually needs. So 95% of their issues is from a lack of insulin. This is the treatment for the hypoglycemia, yes, but more importantly, this is the treatment for the acidosis. This is what they actually need to fix them. This is what will save them. By getting rid of the acidosis and stopping the ketone production, they stop the acidosis. Their pH goes up, and all the badness stops. Right? Not really an EMS thing, but something to be aware of. And then finally, we have the underlying issues, right? Just like, is it pneumonia plus DKA, MI plus DKA, stroke plus DKA, etc., right? We always have to keep in mind that there might be something else going on that's causing the DKA. All right. So, en route, you avoided intubation. You deferred the O2 because their stats are fine. She was hypotensive for you, so you started 2 IVs. These patients need a lot of access anyway. You gave a liter of saline just because that's what you had over like 10 to 15 minutes, and you started her at 500 mLs an hour for the rest of the trip. Got to the hospital. She was given insulin. Her potassium was repleted, and she was admitted to the ICU ultimately for further care. Basically, her anti-gap acidosis went away in about 8 hours. She was transitioned to her normal basal insulin, and then she was sent to the floor and then discharged a couple days later without patient follow-up. So, good job. We fixed her. These patients are super fun. They're super interesting. I really love DKA and kind of the patho behind it. So hopefully you guys picked up something. That's all for the case. Thanks for checking it out. Hope you can take something away from it, or at least it was a decent review of the cool pathophysiology. I don't know.